this presentation, the aim of this is that we should discuss and we should see what is happening, the use of the stem cells as a tool to optimize the poor ovarian responders as well as the patient who have primary ovarian insufficiency. Little bit of definition, what is primary ovarian insufficiency? That is, woman she is less than 40 years, but she has gone into the poor, that is the menopause. Her FSH level has risen and the estrogen level falls. She is not having any menstrual cycle, and this term is used as a primary ovarian insufficiency. Then what is POR? POR is in the context of the IVF. That is, you are stimulating the ovaries, controlled hyperstimulation with the gonadotropins, but you don't get the response. Follicles may not grow, you may have to abandon the procedure, or if the follicles grow on the ovum pickup, you don't get any ovum. So the definition is when you get less than 3 eggs after the controlled ovarian stimulation in the context of IVF cycle. Mostly the etiology, we don't know why the patients, they have poor primary ovarian insufficiency. This may be mostly they are idiopathic, but they may be the combination of the inherited factors. That is, it may be chromosomal, autosomal, genetic problem, immune disorders, iatrogenic injury because of surgery or chemotherapy or radiotherapy. As already said, that maybe mostly it is idiopathic, we don't know. Mechanism appears to be that is there is accelerated loss of the follicles. That is, they undergo depletion. So the patient undergo earlier menopause. She is less than 40, but she doesn't have menses. Her levels of hormones, they are in the range of the women who have already menopause. So what are the options? Till now we are talking about PRP, stem cells. There were no options, only egg donation was the option. But to the most of the patients, this is not acceptable because they are not capable of producing the genetic children. So it is very distressing, that is to get, to diagnose, and you say the woman is less than 40 and you diagnose that your ovaries already stop functioning. It's very distressing. So what are the options? Little bit of the physiology. That is, at 20 weeks of gestation, female fetus has 6 to 7 millions of the eggs. But at the time of the birth, they undergo depletion, undergo atresia. So only 1 to 2 millions they are left. But at puberty, then it is 300,000 to 500,000. By the time she reaches 35, there is rapid fall, and at the age of 37, roughly only 25,000 of the follicles or the eggs they remain. And around the age of the 51, that is average of, even in Pakistan, 50 to 51, and this was from the United States, that is only 1,000 oocytes remain. So our role, where the role of the PRP activation and the stem cell role they come, that is the few of the residual follicles, they are quiescent. They are not responding to anything, but those follicles, they can be rescued and they can be developed by some mechanisms, by some therapies. What are those mechanisms that those residual or quiescent follicles, they can be activated? There are 3 modalities of the treatment at this time they are happening in the world. One is the in vitro activation. Second is the platelet-rich plasma directly into the ovaries. And third is the use of the stem cells into the ovaries. Little bit of the what is in vitro activation. That is, we already know, the gynecologist must be knowing, that is after PCO on the patient, when we do wedge resection, they start ovulating. Previously, so what is the role of this activation and fragmentation or the incision of the ovaries? They say that is hyposignaling that is interrupted. Hyposignaling causes the depletion of the follicles, atresia of the follicles, or apoptosis. When we give incision, they get activated. This study was published by Kawamura, and this study was carried out in Japan. And I'm sure I was a bit of late. That is lot of talk on PRP and what is the role of the PRP. We already know when we get the PRP, 3 to 5 times the growth factors level they increase as compared to the peripheral blood. And these follicles, these are the name of the growth factors which we get from the platelet-rich plasma. And what is their role in the context of the infertility? That is, they are responsible cell proliferation chemotaxis, differentiation into the mesenchyme and other cells, and they promote the angiogenesis. So this is the process PRP preparation. Infusion is just like that is transvaginal ultrasound, and there is a needle attached, you directly inject it to the ovary. Various studies, but they were all the case reports, and they got successful pregnancies after the PRP injections. This is another case series, that is they carried out autologous PRP, and they were able, that is the markers of the ovarian reserve, FSH level, they fell, and marker of the, another marker of ovarian reserve, AMH, that increased after the PRP. So another data of in vitro fertilization, they were able to get the IVF treatment to offer them each patient one blastocyst that was prepared. That is the PRP. But we don't know what is the mechanism of action of the PRP. It is a complex process, and the cross-signaling between the factors we don't know yet. And the studies which are being published, they are case reports. Larger randomized control trials, they are not available. So then the scientists, they were aware of the regenerative role of the stem cells. These stem cells, what is the source of those stem cells? They are embryonic stem cells which are got from the blastocyst, inner cell mass, but that damages the blastocyst, and that will ultimately lead to the malignancy of the blastocyst, that is the teratoma. So, but they are pluripotent cells. Then came the idea of the mesenchymal cells. The mesenchymal cells, they are obtained from the mesoderm source, and they can be, they are multipotent. They have the potential to delineate into the chondrocytes, hepatocytes. Even recent studies are coming that they can convert into the neural tissue as well. So the sources of these mesenchymes, they are from the umbilical cord, from the fat, from the amniotic membrane. And that is, what is the function? We have to see the function of the stem cells, transplantation to the ovaries, what is their role? The general role, we know that is they are anti-apoptotic. The follicles which are residual, they help in maintaining their growth, and they modulate the immune response and anti-inflammatory properties. Factors which are released, chemokines and mitogen proteins, these are able to promote the proliferation and the neoangiogenesis. So the role of these stem cells, mesenchymal stem cells, in the context of the IVF or infertility. Many preclinical studies in the animal rodents, and those rodents or the mice, premature ovarian failure was induced by the chemotherapy, and then they administered the ovarian mesenchymal tissue directly into the ovaries of the mice, intraperitoneal or into the rat. And what they found? That is, there was high replication capacities. Those stem cells, they migrate to the injured ovaries, and they have the differentiation potential. So mechanism of action, we already said that these cells, they can do angiogenesis, anti-inflammation, immunomodulation, anti-apoptosis, and anti-fibrosis. We don't know whether these MSCs, they can differentiate into oocyte, but these involve secretion of the cytokine. They have the paracrine roles. So when we inject into the ovaries, they act by the paracrine roles. That is, they secrete the various growth factors that help in the growth of the remaining follicles. So we are able to obtain a good portion of the eggs from those. So this is a diagrammatic representation, that is, ovary may get damaged from the ovarian injury, from the oxidative stress, and as well as, so what these stem cells, they will do, the various signals of the follicular depletion, they will be interrupted, and the follicular growth will take place, and ultimately mature follicle, pre-ovulatory stage, and ovulation. That is the various growth factors as well as interruption of the signals which are responsible for causing the depletion and the interruption of the growth of the follicle. So we talked about the preclinical studies in the adult rodents and the mice. Then the various studies, they were performed in the humans. Although those studies, they obtained the mesenchymal stem cells from the body. Please ये देख लो क्या हो रहा है, चलते हैं. So the clinical studies in the humans, they got mesenchymal stem cells from the bone marrow and they injected either laparoscopically or via the transvaginal ultrasound performing directly into the ovaries. But most of the studies I have over here, this first study, that is idiopathic premature ovarian failure, bone marrow aspiration, directly injected into the laparoscopically into the ovaries. And these studies, that was by Adesi in the Egypt, and ACTA Medical Frontiers, this study was published, and there were 10 patients less than 40 years of age, and MSCs, they were directly into the laparoscopy, and the patients, 20% of the patients, they resumed their menstrual cycle. And 3 months after, they got one pregnancy and one live birth. The patient, 10% of those patients, they underwent the fertilization. Another study that was presented at the Global Congress on the tissue engineering that was carried out in 2016 by the Hala Gaber, and they took 30 patients. They were the 30 patients, and the direct infusion of the intra-ovarian laparoscopically stem cells obtained from the bone marrow, they was injected. And they were able to get hormonal profile 4 weeks after. 86.7% of these patients, they have the ovarian reserve markers improved, that is FSH as well as the AMH. 60% of those patients, they showed ovulation, and 3 patients of those 30, they underwent the IVF. Then another case studies that the 2 patients with early ovarian failure, they had stopped their menses, their estrogen level was less and their FSH level higher. When they were treated, both of them, they resumed their menses. Their ovarian size, even after 12 months, end of the study, remained 2 to 3 times higher, and their estrogen level, even after 6 months, they remained higher. Their post-menopause symptoms were ameliorated, and they resumed their cycle regularity. This study that was in a very esteemed journal, Fertility and Sterility 2018, this study was published, and this is said to be a paradigm shift. That is, you don't need to do an invasive test of the bone marrow, you just give colony granulocyte stimulating hormones for 5 days, and those bone marrow stem cells, they mobilize into the peripheral blood, and that peripheral blood is then by cell separator, you separate them and you get the bone marrow stem cells, and then you inject into the ovaries. So this is the process that I've shown, that is bone marrow stem cells, they can be mobilized by the injection of the colony granulocyte stimulating hormone to the patient, and from peripheral blood you can get those bone marrow derived mesenchymal stem cells. Then laparoscopically they were injected into the ovary. And this is the very amazing results, that is the AFC, that is antral follicular count, that increased significantly. 4 weeks after ovarian reserve increased in 13 patients, that is 81.3 patients, they have improved ovarian reserve. ART was possible in poor ovarian responder patient, and the pregnancy resulted in 33.3% of the patients. So it is a semi-invasive and easily reproducible method, and it optimizes the mobilization of existing ovarian reserve. So the stem cells, they can be mobilized and injected. So ovarian reserve markers, even the pregnancy, cycle regularity, increase in the estrogen level you can get. This is our small study. We are working at Concept, Australian Concept Infertility Centers, and we wanted to find out what is the role of intra-ovarian transplantation of adequate tissue-derived SPL in women who are co-responders. This is an ongoing pilot study, and up to now we have done 5 cases. And the women, they aged between 25 to 43 years, undergoing in vitro fertilization. Previously, they showed a poor response, either no follicle developed after the controlled ovarian hyperstimulation, or if the follicles they performed on ovum pickup, we did not get ovum. And exclusion criteria was, that is, if the woman is suffering from any breast cancer or the ovarian cancer, they were then. And from where we got this FEF, that is from the Dr. Bushra D stem cell lab. So method, I think you must have already taught, that is from 50 to 100 ml of the fat, they get it in and they add collagenous 4 and it is broken down, it is sieved and ultimately it is suspended in PRP, and by the time they provide to us according to the laboratory, that is the 1 cc of this SPF that contains 2 to 6 million of the cells. And in each ovary we injected laparoscopically 2 cc. And suppose the amount of the mesenchymal stem cells, that was 4 to 12 million in each ovary. This is the procedure of laparoscopically. We stabilize the ovary and then we directly inject into the stroma of this SPF. So this is the data, that is the pre-response data of the patients. You can see over here, the number 1 patient, she was already 39, FSH was in upper range, but AMH level, that was in very low ranges, undetectable. Follicular count, that should be 6 to 7, it was 3 to 4. So all these parameters, they were of low ovarian reserve. She was given maximum stimulation, and after maximum stimulation of granulotrophin, we were able to get only 1 egg. Second patient, that is AMH level is again 0.3, AFC low, and 6 granulotrophins, that has to be abundant because no follicles were recruited. Third patient, she has 0.1 AMH level only, maximum granulotrophins, 2 follicles grew, and we were not able to get anything out of this. And then the fourth patient, that is again we were able to get 1 egg out of 5 follicles and after maximum dose. Fifth patient, although she had this procedure done and her AMH level did not change, she was lost to the follow-up. So this is the data of the 5 patient, and this is the after they received. You can see that is AMH level marginally improved, and after minimal stimulation, that is with tablets instead of the expensive granulotrophins, we just gave them minimal stimulation with clomiphene citrate and with granulotrophins, and we were able to get 1 egg of the 3 follicles, and this patient is being prepared and followed, and another patient 2 eggs after 3 follicles and up 2 months after the follow-up. The follow-up is usually carried out for the 6 months, and after every 3 weeks, their AMH, FSH and ultrasound for the enterofollicular count should be done. Our result there that show that in the 60% of the patient, the marker of the ovarian reserve, that is AMH improved, and cost-effective medication, that is simple clomiphene citrate and the low dose of the granulotrophins, we were able to get in those patients as where there was no response. So this is known as the autologous stem cell ovarian transplant, S4. So it is a paradigm shift for fertility treatment for the primary ovarian insufficiency as well as poor ovarian responders. Further work in larger population is of course needed before considering it a real alternative for managing the patient with impaired ovarian function. But at present, evidence is current. Most of the studies, there are 10 cases, 30, 17, and at our center, it is ongoing study, and we have done 5 cases. We got encouraging results. Thank you very much.